So welcome to the third lecture in our lecture series about emergency ultrasound and trauma scanning, and this is where we get into the meat and bones about the EFAST examination itself. What we're going to talk about is performing a trauma ultrasound, what does positives and negatives look like. We're going to talk about cases in another talk, and we're going to talk about the practice and practical on the day when we meet you. So this is all the theory that you need to have done so that when we get to the day itself, we can get straight into the practicalities of scanning. So EFAST is the acronym that was extended from the original FAST examination, which was the focused assessment by sonography and trauma, and then it's been extended to include the thorax and lungs. It was initially done in unstable patients where they were trying to look for fluid that was within the peritoneum, and that was by inference was suggested that when there's free fluid within the peritoneum, the likelihood of that being blood in the context of trauma is very high, and if they're unstable, it was a decision-making tool for patients that should go promptly to theatre. Core questions remain very similar, so we're looking for abnormal fluid in the pericardium, abnormal fluid in the thorax, or in the peritoneum, and we're trying to tell whether we can say that the lungs are inflated, and often with much greater accuracy than our clinical examination and much greater examination than basic radiology. In the key principles we know of ultrasound, we know that fluid tends to be anechoic and typically will appear black, whereas air and bone reflect, giving a bright border with shadows behind it, being echogenic. But we also need to consider the effect of gravity, where fluid is going to naturally flow to and be in a dependent site. Key sites that we're going to be examining, we're going to examine anterior thorax, both right and left side, looking for lung sliding, which is evidence that the lung, visceral and parietal pleural are both in contact and moving relative to each other. We're going to look in the right and left upper quadrants to see both lung sliding and to try and detect pleural fluid. And moving very slightly down from there, we're going to look for fluid in Morrison's pouch, or in that spot between kidney and spleen on the left side, your renal space. And we're also going to look in the pelvis in transverse and longitudinal planes. And finally, we would tend to look at the pericardium to look for pericardial fluid, admitting that the presence of blood or fluid around the heart in blunt trauma is fortunately quite unusual in the Australian context. But these are your key sites where you're going to perform your examination. But it's important that we consider gravity, because your patient will not usually be standing up for the examination. They will hopefully be horizontal on the barouche, and what that will mean is that your air will travel dependently, is going to be up here, and fluid is going to be down here. So when we're looking at the examination, fluid is going to be much more dependent, and air, and most notably pneumothoraces, are going to be more dependent here. Not like your chest x-rays where you have an erect patient where your pneumothorax is going to preferentially reside up at the top of the thorax. When we look at the chest, we're looking for this phenomenon called lung sliding. We also look at the lung and the bases, but we'll start with lung sliding. We'll have the transducer in a longitudinal plane marker towards the head, and as we look into the chest, what we're going to see is initially a small amount of fat depicted by the yellow, a small layer of muscle and intercostal muscles depicted by the orange, and then at the blue we have visceral and parietal pleura that are both in contact. And they should slide relative to each other, and that subtle sliding movement we can see. Deep to that, you should have shadowing, and you don't see anything terribly much, but the shadowing that's produced by the pleural surfaces here creates this sort of greyish mottled shadowing, whereas the bright echogenic anterior surface of the rib is going to hide everything behind it, so you'll have much darker rib shadowing in the far field. The key place where we're going to be interested is at the pleural surface, which is right here, which is going to look, and we're going to be looking to see if the two surfaces slide relative to each other. And sometimes you can get that sort of slightly shimmering effect. So when we look at the lung itself, in this context, what we're seeing is, as we've said, we've got rib shadows with its dark shadows behind it, and then we've got this pleural surface. And hopefully you can appreciate a slight sliding movement and a shimmering that's occurring across here. And that's what we call lung sliding. If you can't see it, the simple thing is just to reduce your depth. So this is the same thing, only at a shallower depth. So we've got our fat, muscle, and then we've got these two visceral parietal pleural surfaces that are rubbing next to each other, with our ribs and our rib shadows that are happening in the far field. So with reduced depth, hopefully what might have been previously relatively subtle lung sliding, hopefully you can readily see that lung sliding that's occurring in here. Different people imagine it different ways. It's been also suggested that this looks a little bit like ants moving back and forth along that pleural line. The other thing you can do is look within that pleural space and look within that, and it's been suggested that sort of shimmers like a pool of water within that. Both of which doesn't really matter what method you use, but your key looking for is that pleural sliding. If you're really struggling beyond that, you can go to a higher frequency transducer. This is an example of using a linear array transducer, and hopefully now you can see that pleural sliding even more obviously again. We tend not to change to the linear transducer all the time, just for efficiency. If you can see pleural sliding with your curved array transducer, you've got nothing to achieve by also doing it and examining it with your linear array if you're trying to move through things promptly in trauma. Briefly, we're going to mention M mode, which is motion mode that we talked a little bit about in the first lecture. And that looks at whether there's that pleural sliding creates this granular artifact in the lung field, and it's considered to look a little bit like a beach. So with an air of imagination, you can imagine that this looks from this sort of sandy to the beach that you've got there with the sea in the background that we look at. What we're actually seeing with lung sliding is the two pleural surfaces being in contact, and they need to be moving relative to each other. If they're not in contact, then whatever's in that gap will either reflect or it will transmit. If it's fluid, it'll transmit. If it's a pocket of air, for instance, in pneumothorax, it'll reflect, and it'll stop our ability to see that visceral pleura on the surface of that lung that's being hidden by your pocket of pneumothorax. So what happens in a pneumothorax is you're from a normal state where you've got your two pleural surfaces closely in conjunction with each other, and your lung sits deep to that visceral pleura. In a pneumothorax, that gap opens up and is filled with air. And what that air that's sitting in this gap here does is it reflects everything away from this visceral pleura. And so what not only happens is we can't see this movement, so we see no movement there. This line suddenly becomes static and very reflective, moving things away. So this would be an example of a pneumothorax, and you can actually see that the patient is breathing in this context, because you can just see the subtle movements that's in around here. And what I want you to focus your eyes in around here is you cannot see any lung sliding, and this is an example of a pneumothorax. When the lung is or pleural sliding is not occurring, it either means that the pleura are not in contact or they're not moving relative to each other. So certain simple things, like if your patient holds their breath, then the two pleural surfaces will not move relative to each other. And you just need to think about the different clinical scenarios that sometimes that can apply to. Sometimes it's that they've got a previous pleurodesis. It could be a right main stem bronchus intubation. It could be them holding their breath, or sometimes having very, very shallow breathing because they're in pain. All of these things may give the appearance of lung not sliding, in addition to what happens with a pneumothorax. By contrast, if you do see lung sliding, then it effectively excludes a pneumothorax. So this is just an example of a right and a left lung in a patient. And one might argue that we could optimize machine settings a little bit. But what I want you to focus in on is, do you see any pleural surface sliding here? Versus do you see any pleural surface sliding or shimmering at that surface? And hopefully you will see that this is the side that's suggestive that the patient has an actual pneumothorax. If we put M mode through that, we change from that sandy beach that the tides come in, and it's just this endless sea going all the way to the far field. So if you see lung sliding equals no pneumothorax. Now this is in the context of where you have your transducer. So in theory, someone could have a localized small pneumothorax round to the side or round to the back, but for the most part you're looking for clinically significant pneumothoraces. So clinically significant pneumothoraces will tend to follow gravity, so they're going to be the least dependent part of your patient, closest to the ceiling. Small note of be careful, sometimes patients really breathe very shallowly and it can be difficult to tell. They sometimes hold their breath when you're performing an examination, and sometimes pulmonary disease can create very, very subtle lung sliding. So before you go rushing to get out your chest drain kit, think before you rush towards it and think what you might be dealing with. So as we've looked at the least dependent aspect of the lung, we should also look at the bases. And we're going to look for sliding, and because we're in the more dependent area of the place, we're going to look for fluid. So our patient, the transducer will be located in the right upper quadrant, just above the liver, and we're going to look at liver and diaphragm and see that lung. And the place to imagine you placing it is, if you imagine an imaginary point between xiphisternum and bed, if you go halfway between that point, that's the place to put your transducer. So xiphisternum here, bed here, halfway between the two, put your transducer there with a very slight anti-clockwise rotation just to avoid some rib shadows, and invariably you're going to be in almost the perfect right upper quadrant view. For lung, you might need to move very slightly up, but it's a good starting point to begin with. So in this case, we're looking at the right upper quadrant, and we can see a normal pleural surface coming here, and we can actually see not only it coming into view, but we can see those small irregularities on that visceral surface, visceral pleura, moving along, and we can appreciate not only movement but that lung sliding within here. We can also see the diaphragm moving. We can also see liver here in the context of a normal right base. If we were to look at the right base and we see this sort of thing, this is an enormous amount of fluid in this right thorax here. You can actually see the atelectatic lung that's all collapsed down here, that's floating within this sea of fluid in the right upper quadrant. Other ways we can see it is sometimes your patient, you're not scanning quite at the lung tip and it's not right there, but we can also see that fluid towards midline, and that's what's often called spine sign. So what we see is normally our spine will go to here, and then because of an air-filled thorax, it will hide the spine above the diaphragm. But in this case, we've got pleural fluid filling that, and it acts like something that will transmit ultrasound instead of reflect it, and so we can see fluid above the diaphragm here. For those who are adept, you can also see some peritoneal fluid here as well, but we'll get to that a little bit later. So if we want to look from the right lung base and go to the right upper quadrant, as it were, we just literally need to move that transducer a very slight smidge downwards. Usually it's just a couple of rib spaces, and that will be enough to move you down into looking predominantly at Morrison's pouch and the peritoneum. And this is the sort of view that you will be expecting to see. What you're going to see is you're going to see fat first, and you see muscle with a rib that may be more or less prominent depending on how much you've rotated your transducer. You'll see the liver that sits here, kidney, and then this will be where your peritoneum is. And so what you're expecting free fluid to locate is it's going to preferentially follow here. And as we follow gravity from it's going to sit in around and it's going to track along Morrison's pouch, which is the gap between your liver and your kidney. So this is what it looks like in the context of the right upper quadrant. We're seeing a rib with its shadow. We're seeing tip of liver, Morrison's pouch here. This is the kidney, and we can just see one of the hepatic veins coming in here. It's important from moving not only up high, but it's important to track all the way down to try and see the tip of liver, because sometimes it doesn't quite sit within Morrison's pouch and your fluid will track out all the way to tip of liver. So this is an example of a subtle positive right upper quadrant scan, and hopefully you see that anechoic fluid that's just sitting in Morrison's pouch. It's not so obvious up at the liver tip up here, but we're going from lateral to medial, superior to inferior, and in Morrison's pouch we've got that little pocket of fluid. This is another one to just give you an example that when we look at the tip of the liver, sometimes the money shot and where we see fluid is not here, but sitting in around the tip of that liver. And then sometimes you've got someone with much more grossly positive free fluid, and you see this much larger pocket of fluid lying beyond the tip of the kidney, or tip of the liver, sorry. So we now move over to the other side of the patient and reach across to the left side to look at this left lung base to start with, and also look at the leonorenal space, which is the space between your kidney and your spleen. So what we'll typically do, so it's that right side, but to orientate yourself, the best way to go is look for your xiphisternum here, and imagine a line between the bed and your xiphisternum. Go straight back from that, and this time you go more posterior, so 2/3 of the way towards the posterior of the bed, with a slight rotation clockwise to avoid the ribs, and then you're going to be less likely to have some rib shadows. If you were to see your screen, you can imagine that it's going to be looking like this side. So the screen itself will be reflective of this is the head, this is the foot, this is lateral, this is medial, this is the kidney, and this is the spleen. When we look at that view for that lung base, what we're going to see is this pleural surfaces and lung coming down here. We see the spleen sitting here, kidney. We'll often see the vertebrae in the far field with shadows behind it. And that's what it's going to look like diagrammatically. So hopefully that's, taking you back. That's our kidney here, spleen here, and tip of lung coming in here. This is an example of looking at the left upper quadrant, and we're seeing this tip of lung floating in this large pocket of fluid. Those might notice also that whoever's done this has also had their phased array transducer instead of a curved array transducer, but they're still getting diagnostic quality images. This is another example of a static image of left upper quadrant fluid. This is the diaphragm, lung, and a much more subtle amount of fluid above the diaphragm at that lower zone on the left upper quadrant. So you can see that lung floating within that fluid, but a little bit more subtle than what it was previously. Now we want to look at the peritoneum, so we're going to slide that transducer a little bit inferiorly, and we're going to look at that gap between where we've got our spleen, our kidney, and we're looking to see this gap here, which is where we're going to see fluid. But the spleen's a little bit more mobile, so sometimes we'll also see fluid above the spleen. So it's important to try and locate the diaphragm and see if we can actually manage to see above and below the spleen. So this is just looking at the spleen as it moves. You can see the rib shadow is there, but it will often disappear from your area of interest. By contrast, in this circumstance, as the person's breathing, you can see we've got our diaphragm here, we've got our spleen here, and we've got this pocket of fluid above the spleen, and actually not quite so obvious inferior to the spleen. Again, remembering that this is superior, inferior, lateral, and medial. And then this unfortunate patient has the good fortune to have both. So they've got actually fluid above and below. And this happens to be thoracic fluid and peritoneal fluid in this context. You can just see that dome of the diaphragm restricting the fluid on that side. So we move on to the pelvis and we look at that in longitudinal and transverse views and consider the anatomy of male and female. So in longitudinal, we'll put it right in the midline, just above the pubic symphysis and resting on the pubic symphysis, which is often lower than we first imagine, and get an image of the bladder. What we're going to get is a view looking for our screen, which is here, and we're looking for fluid that's going to collect above or posterior to the bladder, or above or posterior to the uterus, I should say, in the female. And in the male, we're going to see it sitting typically above or sitting posterior to the bladder. One might imagine that gravity is not working with fluid being up here, but I can say that it's fairly common that your patients have been walking around before they've come in to see you, because they're often not recognized as more significant trauma, and it may have pooled just in around this surface just here. So diagrammatically, what we're going to see in the female patient, we've got bladder here, uterus here. We're going to look for fluid collecting here and collecting here. So hopefully you can see bladder here, uterus here, vaginal stripe. You actually see the small effect of a ureteric jet coming in here, and you actually see some shimmering of bowel movement that's happening just above the uterus here. This is an example of someone with some free fluid. So what we can see is the bladder here. We see some bowel loops that are sitting within these pockets of pointy-edged black anechoic fluid. And this is yet another example of a longitudinal view of the bladder, which we see here that's contained, but they've got a pocket of this free fluid here. This is, by contrast, a female patient. The uterus is a little bit convoluted on itself and has folded on itself because of a relatively empty bladder, but nonetheless, we're not seeing the free fluid quite so obviously anterior to the uterus, but we're seeing it certainly posteriorly in here. Transverse pelvis is going to be most useful in the, or can be most easy to orientate in the female patient, because they often have a uterus to locate themselves. Things to watch out for is don't be confused with iliac vessels, which can occur out to the side, and they're not free fluid and shouldn't be confused with it. If you're not sure, you can put some colour flow Doppler on it, and the vessels, because they're relatively high flow, should readily light up. So this is just an example of a transverse female pelvis. We're seeing the uterus, transverse of the bladder, and we've got the right iliac vessel coming in here. So this is a transverse pelvis. So what's happening in this circumstance is it's not always obvious what the difference is between bladder and bowel, and so the operator is fanning from superior to inferior, and what we're seeing here is bladder, and this is all free fluid surrounded, or that surrounds these loops of bowel that are here. So bladder here, and then loops of bowel, and this is all free fluid, and what we see is echogenic debris within that, and that can often be what happens when you've got disease or clotted blood within the fluid itself. Just briefly, come back, it's worthwhile thinking about the sequence of the examination that you do. So our core questions within a FAST exam are, can we see lung sliding both sides to effectively exclude a pneumothorax right and left? Do we see fluid in right and left thorax to look for hemothorax each side? And we look to see if we see peritoneal free fluid. So if we see peritoneal free fluid on the right upper quadrant, we probably don't need to ultrasound the left upper quadrant and the pelvis, unless we're not certain. But if you see free fluid in the right upper quadrant, I think you're done from a peritoneal assessment. The only extra information is resolving small areas of uncertainty when you scan the left upper quadrant and pelvis. don't make the assumption that fluid will track where your injury is. So we'll frequently see a splenic injury causing free fluid to be visualized on the right upper quadrant. So it is not location specific. So always try and follow all your core answers across your core compartments within the FAST exam. So the core question is fluid in the chest, pericardium, peritoneum, and can we exclude a pneumothorax? And we'll wrap up with just looking at the pericardium. So this is when you put your transducer onto the just below the xiphisternum. We'll need a little bit of pressure to press down to see tuck under the xiphisternum, and this I've reorientated the screen to give you an idea of what we're seeing. So we look from below up into the chest. So first thing we're going to see is liver, next thing we're going to see is right ventricle, and next thing we're going to see is left ventricle looking up into the chest. But in reality the screen's the other way up, and this is what we actually see. So we'll see liver, right ventricle, left ventricle, and look at the heart as it beats here. So we can see that slip of recognizable liver tissue, and we can look, and we're looking for that around that bright pericardium. We're looking for a big pocket of fluid that's going to be abnormal. So there's a person just orientated it a little bit backwards in this context, probably because they've used a phased array. But nonetheless, it's readily recognizable that we've got left ventricle, right ventricle jiggling around this large pericardial effusion, which is of concern. Just a small note is the old adage of pericardial blood doesn't clot is clearly rubbish. And what we can actually see in this context was actually a minor trauma patient who had crashed their car because of a type A dissection, and this is a large amount of clot within their pericardium that was incidentally picked up as part of their trauma examination due to their different condition that had caused their crash. So in summary, you've got to think about your core questions. Can we see lung sliding and effectively exclude a pneumothorax? Do we see thoracic fluid, pericardial fluid, or peritoneal fluid? Our sequence for doing the examination doesn't really matter so long as you cover all areas, but we're going to look at the right chest, the left chest. We're going to look at the right upper quadrant and scan down from lung to peritoneum. We're going to look in the left upper quadrant and scan from lung to peritoneum. And we're going to look in the pelvis in longitudinal and in transverse planes, and we're going to wrap up with looking at the pericardium. For those that are interested, there's some various different programs and otherwise, and some loops that I had to download from the internet that we must credit here. But otherwise, thanks for listening, and we'll get on to some cases and how you would adapt your EFAST to different examinations that you would more commonly encounter in the rural setting. Thanks for your time.